Good afternoon, everyone. Welcome to the ESID Grand Rounds webinar on vaccination and inborn errors of immunity, a nice initiative from the ESID Clinical Working Party. We have an exciting 90 minutes meeting. I'm Filomeen Haerynck from the Ghent University Hospital from Belgium, and I'm happy to co-chair this session with Anna Sediva, which is a pediatric immunologist from the Motul University at Prague, and also a member of the ESID Clinical Working Party. Within the ESID Clinical Working Party, many years ago, we launched the initiative to update the clinical guidelines on vaccination in patients with inborn errors of immunity. And the recent COVID-19 pandemic emphasized the crucial role of vaccination as the most cost-effective life-saving practice for many infections and also for patients with inborn errors of immunity. It's a great pleasure to welcome these eminent panel members. And first, it's a great pleasure to welcome Stuart Tangye, who is Director of the Immunity and Inflammatory Diseases Research Team at Garvan Institute at Sydney. And based on his tremendous research on B-cell development and also his recent study on the immune response in COVID vaccination in patients with inborn errors of immunity, he will highlight the immune response. And thanks again for joining live this session, although it's midnight for you at Australia. And I also want to introduce and to welcome Géraldine Blanchard-Rohner, who is a senior pediatrician and immunologist at University Hospital of Geneva, treating children with immunological problems. Based on her experience and also the recent review on vaccination guidelines and patients treated with immunosuppressive regimens, she will give you a nice overview on what are the guidelines for patients treated with immunosuppressive treatment. And thanks again, Géraldine, for your help during the latest steps for this final draft.
Yeah, so I guess it's on me now to introduce first Filomeen. Filomeen is really the driving force behind this webinar and also behind the whole project of creating the guidelines for patients with inborn errors of immunity. I guess that you all know her, but again, she is working at Ghent University in Belgium. She leads a group and coordinates research on several categories of immune deficiency disorder. And today she will introduce to you the current status of this big project and manuscript on the clinical guidelines for vaccination in inborn errors of immunity, and you will see her lecture. I am really looking forward to that. And then it's also my pleasure to introduce to you Johannes Truck, who is the consultant in infectious diseases and immunology at University Children's Hospital in Zurich in Switzerland. And his main research interests focus on the translational work in pediatric infectious diseases and also on inborn errors of immunity. And actually this expertise is joined in his work on vaccines. He published several articles you can see, and today he is going to present to us the vaccination strategies in children which were identified by newborn screening. We are also looking forward to his lecture. And after the block of lectures, we will continue with question and answer session. And I also should introduce you the Clinical Working Party. ESID Clinical Working Party, which is chaired by Siobhan Burns. She is working in University College in London. She is long-term involved and interested in inborn errors and immunity. And today she will present to you the work of the Clinical Working Party, especially on guidelines, and she will participate in question and answer session. And last, I have to present to you also Andy Gennery, and welcome. By coincidence, Andy is in Australia today, so it is also a difficult situation for him. I believe you all know him. He is working in the University of Newcastle. He's made really a long time involved in bone marrow transplantation in inborn errors of immunity, and he is also working in several other fields and categories in these disorders. And today he will participate in question and answer session, and he will somehow present his experience, especially with these vaccination bees. He is co-chairing that project with Filomeen. So I think we have a great, structure of faculty today, and maybe we can start with the presentations.
Yeah, and before we give the word to Stuart Tangye, we want to thank all the participants. We just heard that more than 400 participants are joining this webinar, which is really exciting. And as this webinar has the goal to be interactive as much as possible, and especially to exchange our experience with all of you, we really want to encourage you to ask questions in the Q&A box. If you have some practical issues, then you can mention that in the chat box, and the people from Gennery and ESID, they will help you. So enjoy the session.
Okay, thanks very much. Hopefully you can hear me. I'm just waiting to get control. This is the story of my life. Thanks for inviting me to present in this ESID Grand Rounds, particularly with many friends and colleagues on this panel. So as Filomeen and Anna mentioned, I'm going to talk a bit about vaccination in the context of inborn errors, with a particular emphasis on COVID-19 vaccines. But before I get to some of the data that's come from the lab and from work that we've been doing lately, just a general introduction to B cell biology, which I'm sure you all understand. But naive B cells, once they are generated in the bone marrow and encounter specific antigen, antigen-specific CD4 T cells, antigen-presenting cells, and so on, they can undergo a number of fates. They can rapidly become plasma cells and produce protective antibody. These cells are fairly short-lived. Or they can enter a germinal center reaction, undergo key events of affinity maturation, somatic hypermutation, selection, to give rise to plasma cells or memory cells, which are really important for long-lived humoral immunity. Now, this is obviously a very simplified cartoon of what we think and understand about the kinetics of human B-cell responses. You have sort of a lag when you see a vaccine or infection for the very first time. And that's because you have activated naive B cells taking off and gradually becoming those short-lived IgM secreting low affinity plasma cells, which give initial host protection. Those cells reduce in number over time, but then when you get infected or re-vaccinated, the memory response kicks in, the dwell time is much reduced, the magnitude is greatly heightened, and this is what really gives you that protection against infectious diseases. And that is true, I think, and that's true for antigens in the context of infection or vaccination. And obviously that was a cartoon, but this is what some real data looks like. These are some terrific papers going back nearly 20 years now, which actually showed the longevity of humoral immunity in humans. And this paper on the left actually is a figure from a paper from Shane Crotty and Rafi Ahmed, showing the longevity of memory B cells specific for one antigen, that being vaccine, so the smallpox vaccine. This is a vaccine which is administered just once, and because smallpox is largely eradicated, you're only largely to be exposed to those antigens in the form of the vaccine. So following initial vaccination, you can detect about 1% of your B cells are specific for the vaccine. That declines typically in this sort of decay curve. But 10, 20, 30, 50, 60 years later, a very similar proportion of B cells persist and can continue to be detected decades later following single exposure. That measures B cells, and this measures antibodies. And again, you can see titers for antibodies against different vaccines, different infections, are relatively constant over 25, 30 years in this one individual. There's some fluctuation, of course, and there's some indication of boosting or reinfection. But by and large, antibody titers are fairly constant and have a half-life of between 10 and 1,000 years, depending on the pathogen. So you can see the humoral immunity mediated by memory B cells and plasma cells, the products of that germinal center reaction, are very long-lived. So just shifting to vaccination in inborn errors. Firstly, the ones to avoid. There's this really nice review from a couple of years ago from Loya Poyanen outlining the pros and cons of vaccination in some inborn errors. And this is just a reminder to many of you, and you probably all are very familiar with this anyway. Live vaccines tread with caution when it comes to inborn errors. BCG in the settings of individuals who have Mendelian susceptibility to mycobacterial disease can develop BCGiosis and have all sorts of problems. But then live viral vaccines against rotavirus, polio, or the measles, mumps, rubella, varicella vaccine can also be very problematic in individuals with particular inborn errors. So I'm sure the Working Party will come back to this in a minute. However, studying inborn errors of immunity is incredibly helpful to tell you what components of the immune system are required for a robust humoral immune responses. And I'm just going to show you some literature going back 30 plus years where it's been possible to delineate the efficacy of vaccination in some inborn errors. So these are patients who were described as having hyper-IgE syndrome. They probably had STAT3 dominant negative mutations. This was in 1988, so 20 years before Menegishi and Steve Holland and Bodil Grimbacher and others identified STAT3 as the cause of this condition. So we don't really know the genetics, but assume it's STAT3 dominant negative mutations. You can see antibody levels against tetanus are greatly reduced in these 11 or so patients. That's just one example. And then a few years later, this study from Becky Buckley's lab came out. And this really sums this up, why it's important to do these studies, because these patients have actually normal levels of total IgG and, for example, IgG1. So that's just polyclonal immunoglobulin. So arguably, the patients don't have hypogammaglobulinemia, but they have normal levels. But when you start looking at antibody levels against diphtheria, tetanus, the patients, these 11 patients here, most of them have very poor responses following, 2 to 4 weeks after boosting for diphtheria, tetanus. Their levels don't rise sufficiently to be deemed protective or functional. So they have functional antibody deficiency. And very much thanks to, largely, I think, to Hans Ochs and his Phi X174 bacteriophage, there's been some really elegant studies on primary and secondary immune responses in patients with inborn errors. So again, these are these hyper-IgE syndrome patients, probably STAT3. This is like what I showed you before, the kinetics of a primary response goes up, comes down. So in the patients, it's not too bad. It sort of sits below the bottom end of the healthy donor range. But then when these patients get boosted, it really looks like another primary response. It sits well under the normal range. And it really just looks like a repeat of a primary immune response. There's no rapid recall. There's no amplified response, unlike the healthy donors. So that's hyper-IgE syndromes. Just extending that to a couple of other conditions. This is actually some work from my lab that we published a dozen years ago or so, showing patients who are known to have STAT3 deficiency certainly have reduced titers to tetanus compared to healthy donors. This is the work from Rafe Jiha's lab looking at DOC8 deficiency, again reporting that in a handful of patients, the levels of antibodies to tetanus, hepatitis, Hib, and parvovirus are greatly reduced compared to what you expect to see in age-matched children. And again, this is another study using bacteriophage as a neoantigen in immunodeficient patients. This is focusing on patients who have defects in class switch recombination. Again, this is the healthy range for healthy donors in the gray. And you can see, depending on the genotype, the responses generally fall well below that of healthy donors. So the primary response, secondary response really isn't initiated, established, and maintained in the context of these inborn errors. And my last example in this context, again, relying on bacteriophage responses, can really highlight some interesting aspects of humoral immunity that you may not have appreciated previously. This is one example of IRAK4 deficiency, so TLR, signaling defects essentially. Again, very reduced primary and secondary response. And this is corneal Netherton syndrome. So SPINK5 mutation typically have increased IgE levels and barrier function. A couple of patients here, again, showing you can have a reduction. So it's a really good model to test, particularly in the context of patients who have normal levels of polyclonal immunoglobulin, but they may certainly have clear evidence of a functional antibody deficiency or a specific antibody deficiency. So basically, when you think about B cells and how they operate, there's a whole lot of surface receptors in addition to the B cell receptor, and a whole lot of signaling pathways. And a lot of these pathways can be disrupted by particular inborn errors of immunity. And if you do have those defects, it's very possible that you have an impaired or blunted or ineffective humoral immunity to natural infection and by extension vaccination. So of course with COVID-19, many people became very interested in looking into the efficacy of vaccination for several reasons. One obviously is to know, do the vaccines work in inborn patients with inborn errors? The other is, from a more basic perspective, is to understand what it takes to generate and maintain a robust humoral immunity in the context of primary and secondary responses. With the exception of bacteriophage FIX-740, it's quite hard to do that in the settings of following primary and secondary and subsequent responses. So this is just a reminder of that cartoon I showed you in a way, but this has been adapted from some work, a review that Shane Crotty and Alexandra Setti published a few years ago, just outlining that you have an early innate immune response, and then it's followed by your adaptive immune response, T cells, B cells, antibodies. And that's when you sort of hopefully see attenuation of viral control and positive outcomes. But what does this look like in patients with inborn errors of immunity? So there's already been quite a lot of work done in this space to varying degrees of in-depthness. And this is one paper I just want to highlight from Alexandra Freeman at NIH and many of her colleagues there, which looked at antibody responses. So this is just total IgG levels against SARS-CoV-2 in response to vaccination. Most patients had mRNA vaccines, and there's about 90 different patients here, all in the top panel here, all put together and then broken down into genotypes somewhat in the bottom panel. So healthy donors, these are healthcare workers, showing pre-vaccination, post the first dose and then post the second dose, antibodies to the spike protein, which obviously is encoded by the mRNA vaccine. So as you'd expect, a nice increase in these 26 healthcare workers. But in all of these inborn errors, there's a huge range, as you can tell, and probably as you'd expect. Responses, some intact, some reduced, some don't get off the ground. And when you break that down, you can see this in a little bit more clarity. Patients with antibody deficiency, actually, most of them are not too bad. STAT3 deficiency, as I was showing before, for other vaccines, quite variable, and so on. So there's some really encouraging data out there already looking at antibody levels, but what's missing at the moment, and something that many of us are working towards, is trying to bring it all together in the context of CD8 T cell response, CD4 T cell responses, neutralizing antibodies, and of course, protection against variants of concern, and also molecular changes happening in the setting of affinity maturation. So a couple of years ago, I started this work, and very fortunately and generously with many colleagues around the world and also around Australia, and really want to call out Filomeen here, who has been incredibly helpful and supportive and instrumental in getting this work moving. But all these people you see on the list on my map here have provided samples from patients with inborn errors who were undergoing vaccination against SARS-CoV-2 and collected serial samples over extended periods of time, and made arrangements to have them shipped to me in Sydney and for my lab to work through these patients. So I'm just going to show you some preliminary data of this. We've recruited about 300 patients total, multiple time points for many of them. They correspond to all categories of inborn errors. And again, due to the collaborative and collegial nature of these people I showed you before, we've got quite a lot of patients with defined inborn errors, making pretty good cohorts available. So I'm just going to show you some of this data because it's still very much a work in progress, and I think it will be a work in progress for quite a while. But I'll just show you some introductory data. So I'm just going to talk about B cells at the moment, not T cells. And this shows you what we're doing here using these recombinant spike proteins and RBD peptides to actually detect and enumerate and characterize the SARS-CoV-2 specific B cells in healthy donors and patients. So this is just data to show you how this all works. Healthy donor collected pre-COVID, staining their B cells with spike or RBD on 2 different fluorophores, so you can increase your specificity, and you can see very little if you take blood from someone from 2019 versus someone who has been infected and vaccinated. You can detect memory or spike binding B cells quite clearly there. If you express that as a percentage of total B cells or memory B cells, you can see pretty clearly the spike specific cells ranges from about 0.1 to higher percentage of your B cells, slightly higher if it's memory B cells. Really, you don't see these in people who haven't been exposed or infected to SARS-CoV-2 peptides or the virus. So this is just the first data set, and again, this is in healthy donors actually from Filomeen's recruitment drive. At the moment, this is 10 individuals who were not infected before vaccination, and there's a couple of people who were infected and then vaccinated. And as immunologists, this is the exact data you'd expect to see. You'd have a baseline level if you were infected, and it goes up with vaccination in terms of proportions of spike binding cells. And if you were seeing SARS-CoV-2 for the very first time, you would expect very few, if any, positive cells, and it goes up over time, which it did, which is very reassuring. And the same is true for when you measure total IgG levels to spike, as well as neutralizing immunoglobulin to spike using a pseudovirus neutralization assay. So everything we're doing so far in the B cell context is working, which is terrific. And at least for the healthy donors, the data is as you expect to see, which was incredibly reassuring. So we started looking at a number of patients. The first group I want to talk about are patients who have defects in type 1 interferon signaling. And the reason for this is because, as you'd know, work done by Jean-Laurent Casanova and many other people within the COVID human genetic effort have revealed that if you have a defect in type 1 interferon signaling, you're incredibly susceptible to severe, life-threatening SARS-CoV-2-induced pneumonia. But what happens to those individuals in the context of vaccine responses? So the first data set is here showing data for healthy donors, proportions of spike binding B cells as a percentage of total B cells or memory B cells. And here's a couple of patients with mutations in either IRAK4, IRF7, or IFNA1. And you can see before and after vaccination, you can generally see an increase in the proportions of spike binding B cells. You might ask, why is the IRF7 so low? That's because this person's relatively young. They have few memory B cells, but when you express this as a percentage of memory B cells, it looks pretty reasonable. This IRAK4 patient actually was, this is during acute infection actually, so his response was quite low because it was a very early time point. But the point is, generally speaking, you get a pretty good B cell response even if you can't signal through type 1 interferon. And the same is true when you look at antibody levels. These are healthy donors at these 2 time points after vaccination. And I've just put all these patients together because we've only got a couple of data points. So these are patients who have these mutations, IFNA1, IRF7, TRAF3, as well as patients who are APOSED who have the type 1 interferon autoantibodies. So quite reassuringly, we can say that if you can't signal through type 1 interferon, at least the vaccination can generate specific B cells and neutralizing antibodies to similar levels as healthy donors. I just want to talk a little bit now about STAT signaling, because I've had a strong interest in IL-21 and STAT3 signaling for quite a long time now. So I just want to focus on this for a minute. So this is sort of the data I showed you already. Before and after vaccination, healthy donors, you can detect spike binding B cells very easily. But we started seeing some very interesting data when you looked at different genotypes. So for example, STAT3 dominant negative patients, STAT1 gain of function, STAT1 loss of function, and then some other pathways, PR3 kinase, STAT3 gain of function, CTLA4. And what we found is that STAT3 dominant negative patients after the second and even after the third boost have normal levels of spike binding B cells. This is also seen for STAT1 loss of function, PR3 kinase mutations, but we do see a deficit in some genotypes, particularly the STAT1 gain of function, STAT3 gain of function, interestingly, and also CTLA4 deficiency, which I realize has nothing to do with IL-21 signaling. And just extending that data to look at antibody levels, similar patients here, you can separate out some defects in the memory cell pathway versus plasma cell pathway. So basically, these are healthy donors. These are antibody levels, neutralizing IgG titers here. And you can sort, again, early days, preliminary data, not staking my career on this just yet, but there are some clear patterns here. So the STAT1 gain of function, you get some antibody levels after the second dose, but they decline. Following a third dose, they're boosted. So it's sort of short-lived and then restored. If you look at STAT3 dominant negative, even though their memory B cells are coming up, their antibody levels are not. So they're lagging behind, but with repeated boosting, they sort of approach some level of usefulness, perhaps. And not surprisingly, the STAT1 loss of function antibody response is completely intact. And I meant to take that slide. Sorry, I'm just going to skip over that. So going over time. So just to summarize quickly and put that into some context. So inborn errors can really reveal the molecular and cellular requirements underpinning requirements for host defense. Studies of B cells and inborn errors have defined pathways for B cell differentiation and vaccine efficacy in the settings of specific antibody responses. COVID-19, though, has really shown that we still have a lot to learn, and not all viruses induce the same types of immune responses and long-lived responses. And we really need to get our heads around that, and perhaps inborn errors is going to give us a lot of clues. But so far, the data at least shows some pathways are redundant, some pathways are important for either memory cell generation or antibody production. And hopefully this can inform us about the efficacy of vaccines, but also the need for ongoing boosters in some immune-compromised individuals. So I just want to thank everyone in my lab who's done this work, as well as collaborators across Sydney who are helping out with some of these functional assays, but most importantly, all the clinical colleagues who are distributed far and wide, who are really helping us get this work going. So thanks very much. I'll stop there.
Thank you, Stuart. This was really very impressive data. And also this emphasized the importance of boosting, especially also for COVID vaccination in these patients with inborn errors of immunity. So maybe we can discuss that later on. So thanks again for joining us at midnight for you. So that means that for the participants, I'm sure that many participants have some important questions, especially for you. But we will promise if some questions that we can catch up later on after the meeting. So thanks again and good night. Thank you. So as already mentioned, so the initiative of this Grand Round was launched already many years ago. As within the SCID Clinical Working Party, we had the idea that maybe it's time to have an update on the clinical guidelines. And it doesn't mean that there are no guidelines. Yes, there are many guidelines for vaccinating patients with inborn errors of immunity. But based on my own experience, and maybe this is also the experience that you have in the clinical daily practice, is when you see a patient in front of you, we really want to have an overview, a table with recommendations. And this was the reason why we launched many years ago. So it was already in 2019, before there were the specific rules for guidelines, this initiative. So that's the reason that the method that we used within the SCID Clinical Working Party for these guidelines were expert review. So it's important to mention that. I will just look, yes, okay. So this is a joint effort, and this is also the perfect occasion to thank you also. You can see many people from Europe, but also across Europe. They joined during the previous years with their own expertise, also based on literature. And I'm so happy that we are almost there. So we just finalized the draft and we are in the final step. So thanks again. This is a joint effort by the ESID Clinical Working Party, but of course also in collaboration with INGIT and the IPOPI. So what is different than the other guidelines which are already available? So these clinical guidelines were according to the 10 subcategories of inborn errors of immunity, which are classified according to the International Union of Immunological Expert Committee. So we have an overview of the table with the non-live and the live vaccines, but also in the structure, it's for each subcategory that we have 3 topics. So first, we give some information on the underlying immune defect and the susceptibility to infection, because it's important to know which increased susceptibility this particular inborn error of immunity has, to know for which infections we want to prevent these patients. The second part for each subcategory is what are the available reports on adverse events and vaccination. And based on these 2 topics, then we have the recommendations for this disease, for this inborn error of immunity. This slide has already been shown by Stuart Tangye. So considering vaccinating patients with inborn errors of immunity, for non-live vaccines, for most of the patients, there is no contraindication. But especially for live vaccines, it's important that you check what is the risk and what is the benefit for this vaccine. As you know, so life-threatening infection can occur, as already mentioned, but also, for example, cutaneous or visceral granulomatous disease can occur in patients, for example, with DNA repair disorder, with SCID disorders. So it's important what is the risk, but also it's important, as already nicely introduced and showed by Stuart, is will the patient make a sufficient response to the vaccine to justify its use? So as we know already, the immune response depends first on the underlying immune defect, but also on the type of the vaccine, and thirdly, on the treatment, because I was wondering also with the patients, for example, with the COVID vaccine response, were they treated at the time of measuring with immunosuppressive treatment, which will influence your immune response, and also on immunoglobulin substitution treatment, which is one of the most common treatment of this patient. So we have particular guidelines which vaccines can be given to the patients if they are treated with immunoglobulin substitution or not, and what are the guidelines? How long do you need to wait after you stop this treatment? So this is where we want to go and where we want to end, and we will provide you once we finalize the draft. So we hope within the coming weeks, months. This is an overview of a table. I'm sorry, it's too busy slide, but as you can see here, so you have the 10 different subcategories of inborn errors of immunity. You have the non-live vaccines and you have the live vaccines. So we also separated, for example, for combined immune deficiency, it's important to differentiate between severe T-cell disorders and non-severe T-cell disorders, which is, for example, also the same for patients with immune dysregulation. You have patients with diseases of immune dysregulating and together also severe T-cell defect. So for example, S is in blue, so that means this is a standard vaccine once again, and it remains a challenge because you have different standard regimens according to countries. R means recommended, so it's recommended, and most importantly, and you see here the red color, it's contraindicated. And as you can see here, many live vaccines are contraindicated in the patients with inborn errors of immunity. I don't have the time to go into detail, but this is where we want to end. Importantly, you have a patient, for example, according to, let's say, combined immune deficiency, but please take also into account when this patient is treated with immunoglobulin substitution treatment. So that means that we advise to follow the guidelines according to the subcategory, but also according to the treatment that this patient is receiving. We also defined what we mean with profound B-cell defect. So if you have a patient with immune dysregulation and a severe T-cell defect, you will have a different recommendation in contrast when the patient doesn't have a severe T-cell defect. So this is where we want to end at the end. Besides, we give a summary on the different subcategories. We also give guidelines on vaccination before and after transplantation, vaccination under immunosuppressive treatment, and Géraldine will inform you on that, and also what are the guidelines, and this is really challenging for patients with immunoglobulin replacement treatment. And finally, and also Johannes Truck will inform you about the details on that, what are the vaccination guidelines for close contacts, which is very important. We are happy also that within these guidelines, we have an update on the travel vaccination guidelines and also specific vaccination recommendation for patients with a suspicion, because we are all seeing many patients during immunological workup. What about the live vaccines in these young children? So an update will be given today by Johannes Truck. And that's already a short summary on COVID vaccination and inborn errors of immunity, with highlighting the importance of boosting. So based on the update of the vaccination guidelines, which will be submitted, published, and later on also be available online once we have the final manuscript, vaccination in inborn errors of immunity, I think you are all convinced that is highly recommended. For live vaccines, please consider the risk versus the benefit. And if you have specific guidelines for a subcategory and the patient has T-cell lymphopenia, follow these guidelines, the same if the patient is treated. And we all have the experience also during COVID vaccination, and this has been recently published also on the online survey for COVID vaccination in patients with inborn errors of immunity, so a joint effort by ESID, INGIT, and IPOPI, that it's important to inform not only healthcare professionals, but also patients to avoid hesitance on vaccination. So that's the reason that these fora like ESID, INGIT, IPOPI, and ERN RITA are very important to inform all of you. So thanks again, and many thanks to all of the participants in this guidelines. Thanks a lot.
So Filomeen, thanks a lot for your overview and the progress which was made over the last few years, and we are really looking forward to publication and to work with this really useful material. Thanks again. And maybe I will introduce Géraldine. Géraldine, you were introduced already in the beginning, but you can maybe start with your lecture, because it's really, we will know something about immunosuppressive treatment in vaccination, which was already mentioned before, but it's important. Thank you.
Okay, thank you. So thank you very much for inviting me. I'm very happy to give this talk on vaccination for patients with inborn error of immunity treated with immunosuppressive treatment. So I am the head of the unit of pediatric immunology and vaccinology in Geneva. Tack. I'm just trying to advance the slide. Okay, so there are many disorders of primary immunodeficiency associated with autoimmunity, autoinflammation, as you can see, and more genes discovered every year. And this gene defect associated with autoimmunity can be treated with various types of immunosuppressive treatment, as you can see. So there are all family of immunosuppressive treatment, in fact. So we know that it is good to and very important to vaccinate this population, because they have an immune system which is dysregulated. They're under immunosuppressive treatment, and of course they have an increased risk of infections. However, there are resistance to vaccination because of fear that vaccine can reactivate a disease, fear that the vaccine can be dangerous, and fear that vaccines are not efficacious in these populations. And it should be added that there is often a need to start very early the immunosuppressive treatment to control the disease, and for a very long time. So we don't have that much time before starting the immunosuppressive treatment to update the vaccination. So it is known that in general, only non-live vaccines are recommended for this population, and live vaccines are administered case by case and with caution. So there are very few recommendations and only based on small studies with preliminary evidence. So these patients altogether are often insufficiently vaccinated. And I hope you see all the references which are in the bottom of my slide each time, because I don't see them. Do you see them? Yes, okay, perfect. So they're all there. So first, a small reminder of the cellular activation during infection or vaccination. So Stuart has started with a nice slide showing all the cells implicated in the vaccine response. So if it is important to understand the molecular targets, because of course the immunosuppressive treatment which various targets of the activation of the cells. So when you have an activation of the cells, you can see here you have the antigen presenting cells, which present the peptides. So in the MHC class 2 molecules with recognition by the TCR. So we call it the signal 1. And that induces pro-inflammatory transcription factors. And then you have the signal 2, which is given by the co-stimulatory molecules, so co-activation. And then you have the fixation of IL-2 on receptor inducing proliferation message. And then, as it was shown by Stuart, you have the interaction of B cells in T cells in germinal centers, and then the B cells can differentiate into plasma cells and memory B cells and give antibodies. So there are a lot of molecules targeting this activation of the cells. Here you have the inhibition of intracellular signal transduction and cellular proliferation. So as you can see, we also call it conventional DMRDS. And so they are like, for example, the azathioprine, cis-mercaptopurine, mycophenolate mofetil, methotrexate, which add really into the intracellular signaling of the cells once it has been activated. You also have the calcineurin inhibitors acting here, and the mTOR inhibitors acting here, and then you have also the JAK inhibitors acting here. So this is the possible targets, and then other targets are the analog of CTLA4, like abatacept. Here they act. So they block the co-stimulatory signaling which activate the cells. And then we have what we call the biological DMRDS, which are molecules, monoclonal antibodies targeting specific cytokines like anti-TNF-alpha, anti-IL-1, anti-IL-6. And then you have also the possibility to block cells, so like anti-CD20, like rituximab or ocrelizumab, which block the B cells. So that is a little bit similar to the slide which was shown by Stuart before, but it is very important to remind us how it acts, like the antibodies activation after a first exposure of a vaccine or an antigen. So it takes 10 to 14 days for the antibody to increase in the blood. And then you have this small peak after this, what we call a first or primary antibody response. And then it decreases slowly. So the slide which was shown by Stuart, we could see that the antibody persists in the long time. It's very often with live vaccine, but with non-live vaccine, unfortunately, it decreases with sometimes, and very often under the protective antibody level. And after a re-exposure or booster vaccination, you have a quicker increase in antibody. So 4 to 7 days, the peak is higher. And of course, it decreases more slowly. However, you can see in the red dashed line that in immunosuppressed population, the antibody response is lower, and very often it reach antibody level which is unprotective. And also we give frequent booster vaccination, the peak is very often lower. So there are controversial results on the effect of treatment on vaccine response. As you can see here, it's a study where they looked at, it's a Dutch study actually, where they looked at meningococcal conjugate vaccination in immunosuppressed people compared to healthy people. And what they could see is that comparing to healthy people, the vaccine response and the antibody persistence was similar, except when the people started biological treatment. In this case, the antibody decrease was quicker. And this is another study where you can see that they have looked at the antibody response to H1N1 in people with lupus. And they can see, you can see here that again, they looked compared to controls of the same age. And what they could see is that actually the activity of the disease was very important. So when the disease was active, the people were more likely to not respond to the vaccine, and also when they were on a high dose of prednisone compared to the one who did response to the vaccine. So this is also a very important factor, and even the activity of the disease is even more important than some treatment. This is another study where, which was done actually in Switzerland by a group of Zurich. So they have included a lot of patients with rheumatic disease, so adult patients, and they looked at the antibody response post the mRNA COVID vaccine. And here you can see that this was before vaccination and 1 month after second vaccination. And what you can see is that compared to the control patients, so without medication, so still with rheumatic disease, but without medication, you can see that, sorry, there is an airplane. So the rituximab induce really a lower antibody response. And then abatacept, what was also lower than in the people without treatment. And then the TNF inhibitors, then with in combination or TNF inhibitor in monotherapy or JAK inhibitors. However, with IL-6 inhibitor or what we call conventional DMRDS, the immune response was pretty preserved. This is a study that we have done in our group in Geneva. So they have included adult patients with multiple sclerosis and rheumatic disease under CD20 inhibitors. And they have looked again how they did reply to the COVID mRNA vaccine. So here you can see in terms of antibodies that, of course, as expected, the antibody response is much lower in the patients treated compared to the controls, healthy controls. However, you can see when we look at the T-cell response, it is completely similar, even better in the patients under CD20 depleting agents compared to the controls. And the same for the CD8 response. So this is very reassuring data that even if the patients are on the rituximab, they are still protected with their T cells of maybe complication of COVID. This is another other results that we have performed here in Geneva. So here you can see so here we looked at the innate immune response. So more and more there are data showing that the innate response will determine how the humoral and cellular long-term immunity will be performed after vaccination. And so here they looked 1 day after vaccination, how they did reply to in terms of innate immunity. So they assess IP10, which is a cytokine which is very important for like chemotactism and like for activation of the T cells. And what they have shown is that if you look at controls, people compared to our 2 cohorts of multiple sclerosis and rheumatic disease under rituximab, the response to the innate immune response was very similar. So this is also an argument to still vaccinate people under rituximab. So in terms of safety, we should know that all prospective studies have monitored the occurrence of possible side effects. And here you can see that they have included lupus patients, and they have looked at their response to the varicella vaccine. And so here they have looked in terms of adverse effects. So they had like two groups. The people with lupus were randomized to receive the vaccine or the placebo, and compared to the healthy patients. And what they have seen is that, so that was all, each time it was a booster dose of varicella vaccine. And you can see that the adverse effects are really similar, and have not shown another graph where they have assessed the activity of the disease, which was similar as well in the vaccinated and unvaccinated patients. And here we look at exactly on the vaccination effect on disease activity. This is really a question that very often, like the clinician ask us, especially the rheumatologist. Well, we prefer not to vaccinate because we don't know. We have like a disease which is inactive. We don't want to take the risk to activate this disease, even with non-live vaccine. And really, we should insist and really motivate them to vaccinate, because there is no risk with non-live vaccine. And here it's an example of a booster doses with a live vaccine when they have assessed MMR vaccination in children with juvenile idiopathic arthritis, and they have looked at booster with MMR compared to patients who received the placebo. And as you can see, they have looked at the activity of the disease. So JADAS, which is a score to assess activity of juvenile idiopathic arthritis, and there was no changes. And also in the patients who were under methotrexate, you can see that there was no changes. And also here you can see in terms of activity in terms of flares of the disease. So it was similar in the control groups versus the group who received the MMR. So this is another example of assessment of disease activity after vaccination. So this was after a varicella vaccination. So they looked before and after in a patient with juvenile idiopathic arthritis. They used different scores for assessing activity of the disease. So number of arthritis, CHAC score, global assessment of the disease, and ESR. And it was again similar before vaccination. So it was 3 months, 3 months, 1 month before, and again 1 month and 3 months after vaccination, and there was no difference. So these are again very reassuring. So conclusion, non-live vaccines are allowed under immunosuppression. They are safe and they do not increase disease activity. Best immunogenicity is achieved when disease is inactive or at a lower immunosuppressive dosage. Effectiveness is demonstrated, but lower than in the general population. So there are still poor responders which remain nevertheless more at risk and should be revaccinated. So when possible, we recommend to assess the immune response to vaccination. Then in terms of recommendation, so when possible, before treatment, we should do an age-appropriate immunization checkup and before starting the immunosuppression. So it's at least 2 weeks before for non-live vaccines and at least 4 weeks for live attenuated vaccines. Household contact of patients treated with immunosuppressive drugs should be fully vaccinated. Then it is particularly important to vaccinate with the seasonal influenza vaccine yearly and with the pneumococcal conjugate vaccine. I do not mention COVID, but certainly it is also important to vaccinate against COVID regularly. Then usual vaccines according to age should be given. So do not forget HPV, HBV, meningococcal vaccine for teenagers, Shingrix for people older than 18 years. And then vaccine response, as I said before, when possible, should be assessed 1 month after last dose, because sometimes they need more doses to reach protection. Then live attenuated vaccines are generally contraindicated and can resume 4 to 12 weeks after cessation of immunosuppressive treatment. So the delay depends on the drugs. And then, of course, with this inborn error of immunity. Maybe there are other factors making them at risk of having a side effect with live vaccines. So really, we should measure the balance before giving live vaccines. Then, according to the recent EULAR recommendation, MMR booster and varicella can be given in patients on methotrexate and can be considered in patients on low-dose steroids, TNF inhibitors, anti-IL-1 and anti-IL-6. And if there is uncertainty about the safety of administration of live attenuated vaccine, vaccination should be, of course, withheld, and it is advised to seek opinion from immunization specialists. So thank you for your, oh yes, and this is the references I used, and the bottom general references, and then there is the review I wrote in Frontiers in Immunology, and I also wrote a book with my colleague Laure Pittet. So here are all the access references. And of course, there will be our clinical guidance for ESID working, from ESID Working Party to arrive soon. So thank you.
Thank you. Filomeen, will you introduce the next speaker? Or maybe we can introduce Johannes, who you just already introduced, and maybe he can go on with the next presentation. Yeah.
And at the end, there will be some time for some important questions. So thank you, Johannes.
Good. Thank you very much. So try to navigate the slides. Let me just I think now it works. Great. So, well, thank you so much for giving me the opportunity to talk about some of the important information on vaccination in children with abnormal newborn screening, which I was given the task to cover. So, let me just see if I can. Great. So just a few words on newborn screening. I'm sure some of you, or even most of you, know how this is done, but I'll nevertheless just to put everyone up to speed with how we do it in Switzerland. We've been doing newborn screening for almost 4.5 years now, and we are one of the very few countries who do a combined TREC and CREC screening. And as you may all know, these TRECs and CRECs are both remnants of lymphocyte development. So the TRECs, as shown on this graph here, they are sort of waste products during T cell development in the thymus. They are little circular DNA fragments that are cut out when the T cell receptor is joined or when they're recombined. And because they are only made once in a precursor cell, they basically get diluted as the cells proliferate and differentiate. And so this is a very good marker of thymic function or T cell development in the thymus. And this can be very easily measured in the peripheral blood. And similarly for B cells, there are the CRECs, which are similar, like circular elements that are produced during B cell development in bone marrow and can be detected in the dried blood spot via a PCR. And so as I said, in our country, what we do is have a combined assay that captures both TREC and CREC. And so I'll just give you a little bit of insight what that has told us. I'm not going to go into detail here, but we have like, it looks very complicated, but actually in real life, it's not very complicated workflow, how we deal with these patients. And it's probably not so important to have it in detail, but it's still important to note that once the screening is abnormal, and in our country it's centralized, so we get all the abnormal tests here in Zurich, and they're all looked after by a small team of immunologists. It's still that it takes some time to actually work those patients up, and during that time sometimes you need to make decisions about how to do prophylaxis, not often vaccination because these are younger, these children, but still we have often discussions about how to deal with these patients. So just to give you a little bit of a flavor of what we have detected in the last 4 years of screening, or in the first 4 years of screening. And as you can see here, I've divided those up into severe and moderate. And this is probably quite similar in different countries, and it's just important to get a bit of a balance, what is more common and what is less common. So these are the actual numbers in these 4 years of screening. So we detected a total of 15 what we call severe immunodeficiencies. Most of those are SCID patients, 12, and there are 3 patients with agammaglobulinemia. And then there are quite a few of patients who have a non-severe, mostly T-cell problem, and as you may all be aware, the majority of the ones where we have a diagnosis is actually the microdeletion 22q11, but there are a few others which we have genetic diagnosis for. And the other important population of these patients, actually those patients who don't have a genetic diagnosis, listed here as other T-cell deficiency, despite quite a thorough genetic workup. And just to give you, again, a little bit of incidence data here, we have actually detected many more SCIDs than we would have expected, roughly 1 to 30,000 healthy or live newborns, whereas agammaglobulinemia is actually much more rare. And thinking about the moderate effects, they are actually not very rare, so they're 1 to 8,500. On the ones that we think they are worthwhile sort of thinking about prophylaxis or some suggestion, some management recommendations. And this in relation to the numbers on average, again in Switzerland, about other diseases that are screened, gives you sort of, this is in between cystic fibrosis and the more rare metabolic diseases. So this is just to give you some introductory overview of what we have seen in our country about using these combination of screening. So now moving on to the vaccination topic, and I have during the preparation of this talk, I thought, well, they're actually irrespective of the actual diagnosis, you can split up the type of patient more broadly into, well, 3 or 5 categories, and I'll go through them one by one. Obviously, if the screening is normal, you don't need to do anything, you just vaccinate as usual. Then there are the patients who have low T cells or low TREX, and there it could be either severe or less severe, and you would treat them differently because they have a different risk. And then we have patients who have only a problem with their B cells or with their antibody production, so low CREX but normal T cells. And probably what is relatively straightforward are patients with agammaglobulinemia. And then we have quite a few patients who have some transient, well, I call it transient B cell suppression, or in some of those patients, delayed adaptive immune maturation. I'll just show you what I mean with that. So in terms of SCID patients, when we set up our algorithm and thought about how we deal with these patients, we produced some national guidelines in collaboration with neonatologists, intensivists, and other relevant people, and trying to come up with something that we would recommend for all our patients. And this still holds true. You can read it up, it's open access. And I'll just highlight some of these things because I think they're still valid. And thinking about vaccines for the patient, for a SCID patient, Obviously, live vaccines, as we already heard, this is contraindicated. There's very little benefit, I think, to vaccinate a SCID patient, both because they are soon to be transplanted and they may not respond, so that we don't give any vaccines to these patients. So what about family members? And I was asked to cover that topic as well, and I think this is very important and often not done as thoroughly as it should be, I think. And what we do, we really go through all the vaccine booklets of all the parents and siblings and check their vaccination status. Some of them we even test and give them additional doses of vaccine or complete courses of vaccine that have not been given, because this is often a surprise and some of these parents have not had any vaccine for quite some time. So, and we take a particular importance for pertussis, influenza mid season, and the live vaccines. There was a debate, or we had a debate about live viral vaccines giving to close contacts, whether that would be a risk to the SCID patient. And there's very little data on that, or there's very little actual suggestion that this could be a problem. There may be a theoretical, or there's, I think, one case report about one transmission of a varicella vaccine strain to another person, and therefore we put that out as not, well, it's only possible to actually get that transmission if they have the rash, and this is in a few percent the case. So we would still give it because we believe it's much more difficult to treat the disease if they have it, and we would give it. But if the child, or well, the child develops a rash post-vaccination, we would actually keep them away from the SCID patient as long as the rash persists. Obviously, annual influenza vaccine is very important to all close contacts and should be sort of repeated if not done. And one thing which we is sort of in relation to vaccination, like the passive immunization here, which is IgG replacement. Obviously, all these patients get put on IgG replacement, but also RSV prophylaxis in addition to that. And we have sort of learned it the very hard way that this could be just too tight in terms of timing. When we had a patient with diagnosis of a SCID, and this patient developed RSV disease just after having had the abnormal screening, and despite extensive treatment, transplantation, engraftment, then died of multi-organ failure due to RSV. So this was very unfortunate, but actually gives you some suggestion that this is a very crucial pathogen to try to avoid, and we can avoid it if we are very rapid with giving those patients monoclonal antibodies. So far to SCID patients. So what about the patients with less severe T-cell problems? And here, as I said, most frequently we see the DJORD, or the 22q11 deletion syndrome, or the patient with no genetic diagnosis. And we treat them similar to patients that are often also as young as these patients and may be presenting with heart defects, depending on the severity of the T-cell deficiency. And we often see those on a regular basis in regular intervals to try to assess severity of the T-cell counts, but also the response to vaccination. What we generally suggest those children to be given like an old 3+1 schedule, because that is sort of more moved towards a 2+1 schedule in most of the countries, which is very good for population effectiveness, but it's less good for an individual protection. Obviously, we talked about influenza and the family. That's the same for these patients. And then the live viral vaccine, that depends a little bit on the T-cell counts and how they develop. In Switzerland, the live viral vaccines are given at 9 months of age. Hence, we see those patients often at 8 months to try and see whether we can actually give it. And most of these patients who are diagnosed through newborn screening don't need any passive immunization or IgG substitution. So now coming to the B-cell problems, and that's something where there's very little information, and we have now gathered some experience with that. And agammaglobulinemia is the most severe, obviously, disease of the B-cell system. And here I show you two trajectories of IgG levels in patients who were diagnosed by newborn screening. And as you can see, the IgG levels sort of linearly go down. So gray is the reference values for that age, and then they were given IgG supplementation when sort of they were dropping further here, and you can see that they respond very well. So in terms of vaccinating these children, one information that I think is interesting is where the IgG preparations are coming from, where the donors are coming from, because they may not be exposed to the same pathogens that we are in Central Europe. And as far as I know, although there are quite some secrets about it, they're mostly coming from North and Central America. And so as similar probably to the secondary immunodeficiency that Géraldine has pointed out, we focus on vaccines that also confer T-cell immunity, and we focus on those vaccines that are very important, probably not to a great extent in the preparations, and should give some T-cell protection. And in our case in Switzerland, we have endemic tick-borne encephalitis, hence we give that as well. And live viral vaccines are not considered useful because they are rapidly neutralized by the antibodies in the preparation. So this we don't give. And so the last one is probably the most interesting category of those patients, because it's looking at a variety of different scenarios of B-cell suppression. And as you may all know, this is most common in the context of exposure to immunosuppression during pregnancy. And the majority of those patients, they actually get as a thioprin or as azathioprine in addition with something else. There are some patients who are exposed to anti-B-cell biologicals or steroids, and very rarely to other things like chemotherapy that must be. And what we've learned by treating those patients is that actually the B cells to the gray part normalize very rapidly once sort of the child and the mum are separated. We often don't follow these patients up, so we don't really know exactly how they respond to vaccines, for example, but we have some patients with more pronounced and prolonged B-cell suppression, or they had more heavy immunosuppression during pregnancy. We followed these ones up, but these are special cases. And what we've seen there is that they have a deeper dip of IgG at the nadir, so 3 to 4 months. We've also seen that IgA and IgM take longer to normalize in these patients. And then commonly they have need more doses, they have poorer vaccine responses than what we would normally see. But all of them actually have normal immunity as far as we can tell in the second year of life. So it's transient, but it may be affecting their first year of life, and it's good to follow these patients up and give them as much protection as possible. And with that, I'll come to the end. Some experience from our side, we've heard that infection prevention is for all of these patients essential. We focus on individual protection by giving different schedules or more doses of active vaccines. We also give to some of them passive immunization. There's this strategy of the cocooning, so having like a shell around these patients by vaccinating close contacts, and then follow these patients up with a more individualized approach based on their vaccine responses as well. Thank you.
Thank Thank you, Johannes, for this very useful, I would say, overview. That because screening is rather new, and we are trying to collect some experience, which you seem to have maybe the biggest of us. Thank you all for your interesting presentations. And before we go to question and answer session, maybe Siobhan, as a head of ESID Clinical Working Party, can you summarize or give us the your view on guidelines in general and on these particular guidelines in vaccination?
Great, thank you very much, Anna. I'm going to keep this short because I'm conscious that we're short of time for questions, but I just really wanted to thank Filomeen and Anna for spearheading this vaccination for guidelines for vaccination, which is the first of these guidelines that we've got mature enough to bring to the Grand Rounds. But there are a number of ESID guidelines in development, and we will plan to showcase these and advertise these through the Grand Rounds in the coming years. And we've got a program now, and thank you for people who have suggested guidelines. If you've got guidelines you think we ought to be developing, then please do contact me by email. We've now also got a structure for how guidelines should be developed, and we will be looking to provide some support for that as well going forward. But again, if you're interested in guidelines, please do get in contact. But I think this is an excellent example of how we can develop guidelines for the community and roll them out. Brilliant. Thanks very much.
Perfect, Siobhan. I think it's really, really useful. And also, Andy, you are coordinated with Filomeen, this big project on the developing of the guidelines for vaccination. Can you comment on that, or do you have something to add to the whole program?
I mean, it's a huge job, and very many congratulations to Filomeen for seeing this through. I mean, it's taken a few years now, but I think it's a really important initiative. Many people have been helping put these guidelines together. It has taken a while, but I think it's been worthwhile, and it's very exciting to see that they're almost ready to launch. Yeah.
Perfect. Okay, so I think we have short time for the questions, and they are coming, but they are mostly for Johannes. But before, I wanted Andy also to ask you, because we were discussing how to vaccinate these patients with inborn errors of immunity and dysregulation or immunosuppressive treatment. We already heard about it from Géraldine. Géraldine, you answered almost all our questions, but Andy, do you think that such patients can vaccination induce some flares, or is it really dangerous, or should we really restrict live vaccines?
So I think we don't actually have the data for the sorts of diseases that we're generally interested in. I thought Geraldine's presentation was really interesting, and I was quite heartened by it. Of course, it's a balance, isn't it? Because you might worry that the vaccine might induce a flare. On the other hand, if the patient gets an infection, then that may also induce a flare, and it may be more difficult to control. So I think on balance, we should be trying to vaccinate these patients. Whether you might want to cover them, I mean, for instance, if they've got significant disease, that you might want to bring them into hospital for the vaccine, maybe you want to cover them with antihistamines or something and give a period of observation. I've done that with a young lad with mastocytosis actually recently, who was quite reactive. So I think, the bottom line should be that we really should be trying to vaccinate these patients, but you might need to take one or two extra precautions.
Yeah, I think I agree. And also, what about these patients with lymphoproliferation? They are also sometimes in these acute long time periods, and it's very difficult to squeeze the vaccination in.
Yeah, but again, I think, sometimes we don't follow the schedules as well as we can. But I think, as I say, it's a balance between vaccine and infection. And on the whole, I think patients are better off with the vaccine, and we can do that in a controlled way.
Yeah. Thank you, Andy. So good night probably for you in Australia.
I'll hang around a bit. Yeah.
And just now, there are a number of questions, and almost all of them are for Johannes. You know, you induced interest with your lecture. So we can probably start. This is a question. Could you explain the immunoresponse after thymectomy, or if it has the same, rules as SCID children?
Well, we have, this is, I think, slightly unrelated to the topic of newborn screening, because we see all of these patients just on a general basis. Well, some of the patients, it's hard to know whether they actually have an inherent thymic problem or whether the cardiosurgeon has sort of done its part. And in terms of practical management, I think it doesn't make much difference. You evaluate the T cell counts and the T cell function mostly based on specific antibodies, so mostly to vaccine antigens. And then I personally don't treat them any different to like a DGeorge syndrome patient or charge patient. Just you need to assess function and count. And often thymectomy is not complete, and so they may actually have restored function. But I think these are the patients that actually need a good hand, an experienced hand, and we see a lot of these patients. I think we have a good feel, although it's very difficult to come up with some exact numbers. Do start here, end here. They need to be followed up, and as Géraldine also said, it's like not just a one-time vaccine response that will determine whether you're in a good or in a bad shape. It's sort of the persistence, it's sort of how it develops, and all the other problems. And often they need to go back to have cardiosurgery. So you need to make a call about when to do what and whether it's safe or not. Need some experienced hands, but I wouldn't treat them in general not any different to. For example, the ones where we don't have any diagnosis for T-cell deficiencies. We don't really know how risky vaccines or anything are in these patients. It's hard to know.
Yeah. It's hard. It's hard to develop guidelines for vaccination in these diseases because there are so many variants and individual approaches there. Okay, so just now I see a question for Andy. Which investigations are necessary before administering MRR vaccine after transplantation? Is there CD4 T cell number or some other indication?
So many of these patients are going to be on immunoglobulin anyway. So the first investigation we'd want to know is, are they producing antibody of their own? So, T cell counts, naive T cells are helpful, B cell counts, but IgM level. So because the IgG that you measure is likely to be from the immunoglobulin. Are they making IgM? If they are, we would stop the immunoglobulin infusions and then leave a 3-month washout period. And we would then take a baseline for the vaccines that we were looking at, vaccinate, and a month after the last vaccine, we would then measure the response. We would only be giving killed vaccines initially, and if we demonstrate the response to those killed vaccines, then we'd be happy to move ahead with live vaccines, such as the MMR or VZV.
Yeah. Okay, I think it's also the part of the guidelines, this paragraph on vaccination after transplantation. So we are looking forward to that. Yeah. An interesting question from the country which still probably vaccinates with BCG. And they ask, is BCG vaccine efficacy if given after 6 months same as given after birth? Does somebody have some idea how to answer that?
I'll have a stab. I think it's as effective. I think I don't see why the BCG should be less effective if you're a little bit older. I think the worry is the protection issue, so that if you're not protected, you're more at risk of getting disseminated TB or TB meningitis. But I don't think it's any less effective giving it a bit later. And of course, in countries that are routinely giving BCG and are introducing SCID screening, you might want to move the BCG vaccination schedule to allow you to get a SCID result before giving the live vaccine. But so I think it's fine. I don't think there's any concern.
I think so.
Anna, do you agree that I have some questions for Siobhan?
Okay.
Yeah,
okay.
Maybe I have one question based on the experience as an adult physician, but which can also be used for children, is what about vaccination and immunoglobulin replacement treatment? Because also within the group, we had many discussions on that to have a consensus. So which non-live vaccines would you recommend to give? And which live vaccines would you recommend to give? I think it's a practical question. Yeah.
I mean, you're talking about patients on immunoglobulin therapy.
Yeah, and for whom you cannot stop the treatment.
Right. So, I mean, in practice, we don't give any, we give very few vaccines to our adults on immunoglobulin therapy. We don't give live vaccines in part because I guess of anxiety about using live vaccines in immunodeficiency, and also the issue that I think was raised on one of the slides about neutralization. In terms of non-live vaccines, if the antibodies are likely to be present in immunoglobulin, obviously we don't give it, like tetanus, for example. We do give COVID vaccines, even in patients on immunoglobulin therapy. And in fact, I guess the preliminary work that we've done in adults with antibody deficiency suggests that even in CVID, about half of the patients will make some response to COVID vaccination. And for those that don't, there is good evidence now that T-cell responses are made, although I think the correlation with protection is really not very clear. So we do give COVID vaccines. We haven't really, we give influenza, annual influenza vaccine for the same reason, very few antibodies in the product. And there is evidence that CVID patients or patients with antibody deficiency can make T-cell responses. Again, a correlation with protection, I'm not sure, but I would say that we see relatively little influenza in our adult population who are immunized. And those are really the only two vaccinations that we give routinely to patients. We shy away completely from giving yellow fever vaccination because we are concerned about them getting yellow fever disease. So I think we're actually quite cautious in adult medicine with vaccination in our patients on immunoglobulin therapy.
Thank you. Can someone comment on the practice used for children? Because, for example, HPV vaccines, so there are some vaccines that could be recommended even if the patients are treated with immunoglobulins. Maybe someone can comment, or you can comment, Anna, or Andrew, or someone from the panel.
Maybe Andrew.
I was going to say maybe you. I mean, again, I think, we tend not to give too many vaccines to patients that are on immunoglobulin, but I think even if patients can't make antibody, I think as Géraldine and Stu have demonstrated, you can initiate a T-cell response. And I certainly, the HPV vaccine is safe, it's not live. I would certainly be happy to give that. And, for patients, for instance, with common gamma chain SCID, where HPV warts are a particular issue, you may well want to give it. And a number of those patients don't make antibody, so you might not have any options.
Yeah. I agree, because HPV really brings benefit to these patients, so we really try to give it to them and arrange circumstances. Okay, so back to questions. This is the question about DER22Q11, and if it is diagnosed with no infections in the first 2 years, should we continue withholding live-attenuated vaccines? So, Johannes, what do you think? You have number of patients with T-George, yeah.
Well, we actually, depending on the T-cell counts and the function, we try to vaccinate them as early as possible. I don't think there's any good data that tells you what is safe and what is not safe. We have our own approach, and it works fine. We've not had any issues with that. Some people prefer giving varicella vaccine first because there's a treatment that you can give. And if that's safe, then to give MMR. On the other hand, we often give MMR first because it has been shown in like thousands of HIV patients that, even with reduced T-cell numbers, you can still give it, and we've never had any issue. So usually our cutoff is sort of when time is due for live vaccines, it's like 500 naive T-cells. And good antibody responses to protein and polysaccharide vaccines. In that case, then we've never had an issue with giving MMR. And in Switzerland, until recently, it was not generally recommended to give varicella vaccine to the population. So we also sort of gave it a recommendation to give that, because this is actually much worse if you get the real disease. And so we try to push that, and I think this again, as I said, this needs some experienced hands, and it's not like black and white, but I think with some experience you can figure out quite a safe approach.
I just want to add that also you can find on the SCID register also the definition of profound T-cell deficiency, which we also will use in the manuscript and the guidelines. So first check for that, as mentioned several times also by you, Johannes and Andrew. So check for the T-cell counts, check for the naive CD4 T-cells and for the proliferation. And based on this criteria, you can safely decide if the patient can receive the live vaccines. And then maybe there's one question on steroids, but I have a question, a general question, a question that I receive many times from colleagues. What you mean, Géraldine, with low dose of steroids? Because this is really, what you mean with low dose.
That is true.
Sorry for this difficult question, but it's a
it's a very good question. So it is controversial if you look at the literature, but if we want to be cautious, we should use 0.3 milligram per kilo day. It's also what is used by the rheumatologist, and I think with this dose we don't take a lot of risk really. So yes, and also because with adults you can say like less than 20 milligram per day, but for kids like 20 milligram a day can be really a lot. So I think the threshold of 0.3 milligram per kilo per day is a good threshold.
There's also a related question, because many times in recommendation you read that you can vaccinate safely after some interval after immunosuppressive therapy. But there are patients which have a long time immunosuppressive therapy. There is not this interval. What should we do?
Exactly, it is very hard. And here in Geneva, we are trying to do a research study, because we have like a list of patients we would like to vaccinate against varicella or MMR, and who are like under immunosuppressive treatment. And so, for example, we have a patient with IBD, and we did try to increase the interval between the anti-TNF doses, and we check like the typization, so immunophenotyping. We look at the T cells numbers and B cells, and with that and the interval of 6 weeks, we did vaccinate, and also it is more safe to vaccinate with booster doses than with primary doses. So we did that, and until now we didn't have any vaccine adverse effect. But of course we should do studies and to follow these patients more.
Exactly.
Closely.
So it is 6 o'clock, and we have the webinar Grand Round almost over. We have tried to answer all questions. There are some small details, part questions, or sub-parts of this question we will try to answer later. And maybe, Filomeen, you can end this because you are the really driving force behind that.
No, there's especially I want to end with thanking all of you, so the speakers, for this very nice presentation, practical presentation, and also for the panel members, also you, Anya, to co-chair this session. Thank you so much. I would say good night to the people who are staying in Australia, and I wish you all a good evening. Thank you all for all the participants, and we hope we can inform you once we have finalized. These guidelines will be published and also be online. So meanwhile, if you have questions, we are all here to try to answer your questions. And I think it's also the time to announce the next Grand Round session. Maybe Margarita can share this slide, which will be held on the 3rd of May. And Siobhan, can you continue with the subject of the ESID Grand Round session at the 3rd May?
I think it's the 30th of May, and it's genes. It's where are we with gene therapy for primary immune deficiency? It's going to be a great session, organized by Claire Booth. She's got a fantastic lineup of speakers, and I think it'll stimulate some very good discussion.
Okay, and thanks again also, especially thank for all the many collaborators in fulfilling these guidelines. You all made great work. Thank you so much, and good evening to all of you.
Yeah, good evening. Yeah.
Bye.
Bye-bye.
Thank you.
Thank you.
Thank you.
Bye.